Good afternoon, everybody, and welcome for basically the last webinar of this webinar week. Sorry about the delay. Brent and I needed a bit of makeup done, and we were not released earlier, weren't we, Brent? It's like we were stuck in makeup. Today, we're doing a great session again together with Brent. Brent is a regular on the show, and he's done quite a few interesting webinars. In the last one, beginning of May, we talked about COVID-19, the updates, and we thought it would be great to invite Brent back to give us a new update. And to be very honest, the last one you did, Brent, was pretty, I didn't go home with a big smile on my face, let's put it that way. And I'm not sure how this one is going to be. Like, don't give it away yet, but I guess we just have to figure it out. For people that don't know Brent yet, he's the Director of Medical Instructors and Strategic Customer Relationships at MedAire, and MedAire is a partner that has been with ACRU for quite a few years already, and we're very, very proud to work with them. Joanna and myself are running the webinar, and today we're looking at basically an update on the testing options, maintaining crew health, and the situation updates. I guess that's it for me, Brent. Is there anything you would like to add to that, or would you like to get going?
We'll get going because pretty much what I've got to say will be in the presentation.
Great. So for everybody, we are recording this webinar as always. Please feel free to comment in the chat. Thank you all for joining. We've got England, Mallorca, Barcelona, Spezia, Phuket, Thailand, and of course we got Brent, who's from the beautiful south of England, aren't you?
Yeah.
So I remember that. All yours. You want me to start up your presentation?
Oh yeah.
Here we go. And thank you so much, guys. And we'll speak to you in a second.
All right. Thank you, everybody. So what we'll do is an update on basically the numbers, and they continue to rise. This is a fairly sort of expected occurrence. If you look on the left-hand side, you'll see the US still lead with number of cases, and that's both the number of cases as well as the ability to test keeps on increasing. Brazil is rapidly following up on those lines, and then others will just move down the list there. So it's well and truly a pandemic in every single sense of the word, and as the numbers continue to rise, we'll start seeing some of the more unusual case presentations, which you may have heard about in the news. And one of the key elements to look for is when they talk about numbers per million, it's a good number to use when you're talking about low numbers of unusual or different things that occur in the case count, such as deaths per million, etc. But when you start seeing numbers that are talking about cases per 100,000, that is more, in a lot of cases, more relevant from a medical perspective of some of the more unusual presentations, such as you might have seen something like COVID toes, or some of the pneumonial type stuff, or some of the coagulopathy or the blood clotting effects that occur. So it's a better metric to be measured by when it comes to the sort of the more unusual presentations. So there's a couple of other things to look for on here. The bottom left-hand side is actually quite important. This is a death count, which seems to be the thing that most people are measured against, or sorry, I should say most people, but most countries are measured against, is the numbers of deaths cases. And in a lot of places, they continue to decline. So there was a rapid exponential rise in cases at the beginning, which a few months ago. Then there was a basic plateauing as countries went into various states of lockdown and isolation. And as they come out of that, you should see the numbers start to drop, and that's a good indicator that restrictions should start to ease. But the importance there is the restrictions are easing not because the virus has disappeared, but because it's not as easy to transmit when people are not in close contact on the beaches, having drinks in bars, etc., and having basically free spread of the infection again. So there's a lot of measures that have been put in place to try and mitigate that risk as countries start to come out of lockdown. Some are more effective than others. And so if you look around, this data doesn't really change much. The numbers keep going up. The trajectory changes slightly. You'll see sometimes, though, there's a very wide degree or very wide variance in percentages of fatality. So it's very hard because a lot of that is based on how good the medical infrastructure is in the country. Did they manage to so-called flatten the curve, so not stressing out the medical teams as much as in some places? And that puts a very wide variance on the death or the percentage of the mortality rate. But the best guess is that in a lot of cases, it could be something in the vicinity of 20% more fatal, 20 times more deadly than the flu is on any given year. And that puts it into a bit of perspective. Now, from a risk point of view, here's some of the key risk factors. Again, that hasn't changed much over time. Majority infections are very mild or asymptomatic, meaning that there is little to no symptoms. But you can still transmit and spread the virus. And that's why one of the changes for the last 2 months has been for people to wear a face mask out in public. And it is not so much to protect you from others as to protect others from yourself if you happen to be an asymptomatic or a low symptomatic infection rate. And that has been shown to be very effective in reducing the spread in the community. So that's been adopted by a large number of countries, and seems to be providing some measure of protection. The other one is obviously for risk factors is age, and again, just like most diseases, the older you are, the higher the risk is, and you'll see that from the middle graph, and especially those with existing pre-existing medical conditions. And one of the big ones there is diabetes. Cardiovascular still leads the way, but also chronic respiratory conditions as well. And another one that is probably not identified as well, but obesity is another key risk factor that goes into that. The bottom ones are more for interest's sake. We're not going to go into them in great detail, but there is a fairly sort of a standard, if it's the case, sort of clinical picture. You'll have possibly about a 1 to 7 days of relatively mild sickness in most cases. On a day 7 to day 10, in a lot of cases, that starts becoming more severe. And in some cases, on the 3rd week, there may even be more severe symptoms again that can put people into hospital. So although it might have a very mild or minor beginning phase to it, for some people, and again, it's a very small group, but some people can have a very serious after effects as well. There's an interesting mix between male and female, and there's a number of factors that are sort of trying to be taken into account there. But I believe that we've got probably a long way to go before we actually have a good understanding about all these different numbers and why there are risk factors and why it almost is double, not double, but 2/3 of males versus females are affected more than others. So it's from that side of thing, the studies are going to be keep coming in for many, many years as we get a better understanding about what's going on. But that doesn't help us in the here and now. So one of the things that has been used quite a bit is this what's called an R0, and that's basically how many people the virus can infect and how many people they can infect. And again, in the very early stages, an R0 means that if you do absolutely nothing, what's the growth trajectory like? And most of the models that were used initially had predicted values very, very high, and they were based on what's called a naive model, where it didn't take into any of the real world. It just basically put some numbers in on numbers of people, guesstimated how many people could be infected, and from that, then it looked at what would be the exponential growth. And so for this particular disease, between say 3 and 4 was an initial number, and they would then infect 3 or 4 more, and then you'd see this exponential growth. There's a better number called the RE number, and that's when you start taking measures to reduce the rate of infection. And so some that were used early on in the piece, and probably one of the most important ones, is the social distancing, about 1 to 2 meters between person. You can significantly reduce the infection transmission just by keeping people distance. And that was basically the quarantining, social isolation, isolate in place, etc. Washing your hands and reducing the touch in your face, again, can dramatically reduce the transmission rate to others. And then one of the more later recommendations was to put the face mask on. Again, it's been widely adopted by many countries. So you start seeing the opposite of an exponential growth, and you start seeing a dramatic dropping in cases. But the infection is still there, it is still present, and is still waiting to come out and create new infections, because our best worst guess at the moment is that there is very little, not so much immunity, but a very small percentage of the community have been affected so far. So you may have heard things about the herd immunity. You need up to about 70% of the population to be infected before you start getting this thing called herd immunity. At the moment, with the few studies that have been done in Denmark, Spain, and a few other places, there may only be 3 or 6% of the population has been affected so far. So if you relate that back to the case mortality rate, the complication rate with potential strokes, heart attacks, blood clots, etc., if such a small group of the population have been affected so far, without a viable vaccine or an effective treatment, getting towards that 70% is going to cost a lot in both people's lives and other things as well. So the most important thing you can do to protect yourself is keep those 3 things in mind. Every time you do one process or procedure that's been shown to be effective, you dramatically reduce the risk of both contraction and passing it on. So I cannot overestimate the importance of, again, that social distancing, especially in groups, and as lockdown is freed up, just trying to keep that distance. Make sure you have hand sanitizer, wash your hands, try to avoid touching your face. And if you are in public, and a lot of countries have mandated it as mandatory in public, wear a mask. Now, an update on treatments. There is, at last count, there was about 130 medications currently being assessed for efficacy. Do they work? These are already existing medications. There was a lot of news about them as each one came up and said that it had some sort of improvement or had some sort of effect, and the look was looking very hopeful. They were very, very early studies, and in a lot of cases, they were what's called in vitro trials or in vitro study. That is literally dropping the medication onto a bunch of kidney or animal cells that have been infected with the virus and seeing what it does. And a lot does have an effect. But the problem is an effect on individual cells may not often scale up to be a safe effect on people. And one of the early ones was hydrochloroquine, was another one that was widely popularized both by the American president, as well as some of the early clinical studies also showed that there might have an effect. But unfortunately, as further studies have got underway, many of them have been cut short because the fatality rate for the patients on them was higher than the control rate for the patients that wasn't on them. So it's not looking as a good or even a safe medication to be used both in prevention or treatment of COVID-19 without very strict and direct medical intervention and controls in place. So it's not something that we would be looking at seriously to be putting onto vessels at any stage. Another medication that created a lot of talk and a lot of trials was remdesivir. This was originally an antiviral medication designed to treat Ebola. It was not as successful as they hoped, but as an antiviral with some properties that seemed to work, again, in vitro with COVID-19. And again, the studies are a bit of a mixed bag, which can be very frustrating for a lot of people because it's not easily identified when one trial says, yep, it has an effect, and another trial says, no, it doesn't have an effect. You just have to wait and see. As each trial gets better at controlling for the variables, as each one goes through peer review and gets dissected by experts and clinicians in the field, each trial will get better and better as the numbers increase, and as we get a better understanding, medications will start to be developed and be used that will have some effect. But remdesivir has not been shown to be a major medication in the treatment of COVID-19. It is also a medication that needs to be given IV, so it does limit its use outside of a hospital environment. And like most antivirals, it often has its best effect when there's an active virus in the system. So it's often used in the early stages. But again, it doesn't have a great track record so far with a lot of the studies that have shown. So, but there is a lot of medications being tested at the moment. The other one, and the one that a lot of places are putting their hopes on, is obviously the vaccine. And although it's now been 6 months, the vaccine proponents are still saying it's 12 to 18 months away, and that is fast. We'd have to be very cautious about any vaccine that's brought to market too quickly. There's a reason why these take time to develop. There's, again, has to be sort of trials on safety. Does it actually cause more harm than good, or does it cause more good than harm, I should say? It needs to be scalable. Does it actually work the way it's supposed to work? And when we start putting it into large populations, we've got to make sure that it still maintains the safety and efficacy as it goes up in scale. And both of these, with both medication studies as well as vaccine trials, they take time, and they take a long time to do them well, and they take a long time to review the results and to ensure that they are safe to administer, they're effective, and that they will make a difference. Now, saying that, there is a number of novel ways that they can speed this up that also keeps them safe and takes no shortcuts. One of the ones that can be done is if there is a very strong vaccine candidate in the early stages, they can start mass producing the active ingredient much, much earlier, so that if they continue the studies and safety, etc., if it turns out that that vaccine candidate will produce a safe vaccine, then they've already made millions and millions of quantities of it that can then be brought to market. It's not cutting corners, but it is certainly a way that it can reduce the time to market without cutting any corners. So there's a lot of studies going on with vaccines. Again, there's probably about 30 different companies being looked at, as well as about maybe 6 different ways that a vaccine can be produced. But it does take time. So again, there's nothing that is going to be shortcut to make this a better situation, so to speak. Now, there is a lot of development on testing very early on in the stages, and in some countries it's still the case. It is very difficult to get a test, and but that is rapidly changing. And there are a number of different tests on the market. Tests on the top is the what's called the rapid PCR testing, and that is testing for pieces of the RNA, so bits of the genetic material from the virus. At the moment, it is still a deep nasal swab and is quite uncomfortable. There's a high risk to the people taking it, and other ones that are often used in the drive-through. They do take time to get the information back. It could be 24 to 72 hours in some cases, and that is partly because of the way the tests work. They can take a vanishingly small amount of RNA, so genetic material of the virus, and then it amplifies over time. And so the longer you run the machine, the more amplification of the RNA is made until it's at a detectable level. So if you only run the machine a few cycles and you start getting RNA back, then that's probably a good indicator that you're actively infected. If it takes a long time to get anything back, it probably means that you're previous exposure or previous infection, and there's not a lot of the genetic material left. So that's still considered probably the gold standard when it comes to testing, but it needs to be done by a medical professional, and it needs to be done correctly. There is a high risk to the person giving the test, especially if they're doing hundreds or even sometimes thousands of tests at a time, because of the exposure to potentially hazardous materials and infected people. It does pay to have a professional do it, though, because you could have an error rate of even sometimes 30% if the swab is not in the right area. So even though you are infectious or had contact with the virus, they may not swab the correct area, and therefore there is no genetic material to replicate. Another one, which
Can I just interfere for 1 second, Brent, because there's a question out there from Greg who says, and I know you discussed it a little bit, but I think he wants a bit more detail on the vaccine. do you have any idea what the candidate is? And Philip very kindly says, a vaccine that may be suitable for use to cure the virus. Yes, of course, Philip. But Greg, but is there anything that you would say, what you say has the best opportunity to become a vaccine, or is it's hard to say anything about it?
There's a couple of front runners, and one of the front runners is a relatively novel way of producing a vaccine. So there's lots of ways of making a vaccine, and the traditional way has been to have a virus and either kill it so that the virus is intact, but it can't infect anymore. You inject that into the body, and then the body mounts an immune response, just like it would if you had an infection, and provides the antibodies and the protection necessary. That's a very traditional way. It's a very good way, a very safe way in a lot of cases of making a vaccine. Another way, which gives a slightly better result, is attenuated vaccine. So this is where the virus has been hobbled or damaged in some way that it can't reproduce, but essentially the body mounts possibly even a stronger immune response to it, and that makes it even more effective as a vaccine candidate. So both of those are being investigated at the moment. The unfortunate thing about those is they take a long time, and that's the sad thing. That probably traditionally the two most effective ways of making a good vaccine, and particularly in this case where a lot of people don't mount a strong immune response. These types of vaccines would be good candidates for those, and you can put adjuvants in with the vaccine so that it makes it your body mount a stronger immune response in those cases. So they're the best way of making one traditionally, but they also take the longest, and they are the ones that are being researched heavily. There are some other ones which is almost like rapid prototyping, where you can take out the virus DNA or the RNA and just have the outside protein pieces, and that's a very quick way of doing it. But again, it's you've got to pick the right pieces to keep and the right stuff to throw away, and the body's got to mount an immune response. So there's about 3 or 4 brand new ways of producing a vaccine, and there's 2 or 3 old ways of producing a vaccine. Everybody's doing it. Some of them are even more unique in taking out using almost like a carrier of some description, like a case of another virus, and putting in the antigens or the pieces of the proteins that you want the body to mount a response again, and then injecting those in. So it's not it's harmless. It can't reproduce. It's not the virus as such, but it mirrors a lot of the spike proteins and stuff that's been used or talked about as what the body latches onto for the virus. So as I said, there's lots of different ways. The unfortunate thing is none of them are quick and none of them are easy. And previously there has been some, unfortunately, anything that's rushed to market, you've got to be very careful about quality control. And as it goes into millions and millions of doses, hundreds of millions of doses, it's going to have effects on people that were not understood during the studies. So these have to be taken slowly, carefully, and all the checks and balances must be in place. But as I said, there are ways to speed that up without compromising safety.
Thank you. Thank you for that answer. I'll go away again and leave you to your presentation.
Yeah, not a problem. That's vaccines are quite fascinating, and what I'll do is there was a really good infographic, and I'll find it again, but it outlined all the different ways that they were looking at vaccines, and we can add that to the post-presentation materials. There's also rapid point-of-care testing, and this is looking for something like antigens. So the PCR swab, polymerase chain reaction swabs, we're looking for the actual genetic material. The rapid POC testing is looking for antigens, which are pieces of the proteins. So it's not necessarily the genetic material itself, but it's what makes up the virus. So again, both of those 2 tests indicate exposure to the virus and potential for infection. So so that's one of the very, very sensitive, if done correctly, able to provide within a few days a result. With rapid point of care testing, you can get a result in as little as 15 minutes to 3 hours. And some of these are done by machine, such as Abbott's and Bosch. Other ones are similar to the serology tests, where you take the swab, you break it, you put it into a reagent container, you add the reagent to it, and you'll get a control line, a positive or a negative line as well. And they are very useful if you've got a medical professional on boats, or in a lot of places for the drive-through, or some of the point of care testing that's now been done in doctors' offices and places like that. You can go and have your test and get the results back very, very quickly. But again, like most things, they have to be done correctly for the to be successful. Now, some of these antigen tests, they don't have to have a deep nasal swab. They can also sometimes be done with a shallow nasal swab and a pharyngeal swab. So that's slightly up the nose and on the back of the throat, enough to make you gag. So again, it's not a pleasant experience, but it's certainly something that can provide a quicker result. There is also looking at saliva tests as well. There's still a little bit of controversy over how effective they are, but there are now saliva tests out there as well. Basically spit into a container, send that away to a laboratory, and again, it'll take do some testing. So we're waiting to see whether that is a viable and has a high sensitivity or specificity to it. And if so, that could be a much better option for a lot of people than having a swab up your nose, as someone says, tickles your brain. The other one, which is probably the one that most people have seen and may have even had, is the serology test, the home serology test. As MedAire, we have not endorsed any of these as a screening test for individual people. They are simply not sensitive enough for that purpose, but they do have a very good use in wider populations to try and ascertain how many people have been exposed and are now considered, and I'll use air quotes here, immune to the infection. And that's, again, another whole subject of whether immunity is long-lasting, whether there is a possible of reinfection, etc. The evidence so far suggests that although there might be a very small minority that have been reinfected, most people who have the infection will be immune for a period of time. No one knows what that period of time is yet. Some of the monkey studies have shown that it could be up to a year minimum. On SARS that occurred in 2002, 2003, they had some immunity went for quite a number of years. So it's still a moving baseline on that one. There is the ability to do a antibody test through a laboratory, which is a lot more sensitive, but again, it involves going to a lab to get the test done, and a combination of either a PCR, antigen, and serology test is now strongly recommended for a lot of people to ascertain whether actively infected or had exposure to the virus before getting on board the boat. But that still precludes the use of the serology test, unfortunately. As much as they look promising at the start and may still hold as sensitivity and more specificity of antibodies come onto the market, a lot of these tests, although look very, very good on paper, when you dive into the detail, it pretty much shows that they tested on the most worst case subjects possible. So in hospital with pneumonia on day 10 or day 14, when you're going to have the highest amount of antibodies tested possible. And that's not a bad thing. It's what they're using is to show that the test actually can pick up antibodies. The problem is when you apply that to the real world, where people are asymptomatic or have low symptoms, then the specificity or the accuracy of this can drop quite dramatically, depending on the test. And there's only a few studies that are looking at comparative serology test home test kits, looking at the different sensitivity and specificity of them. And so those studies, although will start coming out and more, are actually quite hard to find, and it's very hard to find one that has that sensitivity needed. And so far, none of them that we've seen can be used as an effective screening tool on board a yacht, unfortunately. But a combination of the of either PCR, antigen, and hospital-based, also a laboratory-based serology test is a good option. Now, if we look at best practices for protecting yourself, your guests, other crew members, and just everybody else, the terms change slightly, but the you can have the red zone. It can be called a transition zone. A red zone, or it could be called a uncontrolled environment, or it could be called a number of things. But anyway, this is where you are out in an uncontrolled environment. So that is either in town, at home, etc. What we'd look at is having a period of time of quarantine or self-isolation. 14 days tends to be the one that's most recommended. And again, it's only a recommendation, not a hard and fast rule. But basically, by trying to isolate yourself as much as possible before joining the vessel, you are healthy. You've limited the risk of coming in contact unexpectedly with an infection, and therefore, when you join the boat, you've had a period of time where you know that you have not been sick. A number of vessels, and in some cases, they might recommend a PCR antibody combination test. Again, this is not the cartridge test. This is both done at a laboratory or a rapid test. And that gives you a baseline as well as confidence that you have not been infected recently or come in contact with the infection. These both have to be done by a medical professional, normally off-site. Drop-offs and pickups. There has been a number of studies that have shown that the virus is viable on different surfaces for a period of time. The one thing that they can't tell us yet is it transmissible enough to make us infected? So you could put a virus on cardboard and it says that it's good for 24 hours, that it's still able to test for live virus after 24 hours. But how much of that live virus needs to get into your system to actually make you sick? So it's not a 1-for-1 ratio. It's not necessarily going to be one virus will make you sick, although there are a very few infections that can do that. Sometimes it could be millions of viruses or even a prolonged exposure before you get sick. So simple precautions such as drop off and pick up areas, try to not touch them or leave them alone for a period of time, say 3 to 4 hours, wipe down the cardboard boxes or open them up with gloves, take the contents out, and try and just to limit the contact with uncontrolled environments or uncontrolled people. If you've got a meet and greet area for contractors or crew joining or coming on or guests or that, then masks and gloves, social distancing would be a good option. And so you limit the risk of an inadvertent exposure. There are several screening tools for both from a paperwork perspective as well as checklists that can help to reduce the risk on board as well. When it comes to the yellow zone, we call this a transition area. And this is where you're transitioning from an uncontrolled environment to the controlled environment, which in this case here is on the vessel. And that's what we consider to be a relatively safe zone. And so sometimes it's a case of having somebody almost like a gatekeeper, no touch, no contact tools, like when you sign for documents, often you pick a pen up, you sign for the document, you forget that you got the pen, you scratch your face, and then there's a potential for inadvertent contamination. The risks are quite low if everybody are practicing the same basic precautions, but the risk is still there. So you want to try and reduce that as much as possible. Sanitizing stations are quite popular, especially where there's a hands-free standalone station. So you're not having to pick up a squeezy bottle that everybody else has picked up, sanitize their hands, because when you sanitize your hands, you put the bottle back down, potentially you could be inadvertently contaminating yourself again. So some of these non-touchless sanitizing stations turn out to be very good. A lot of talk about temperature checks as well, and a lot of boats are taking frequent temperature checks. They're good if you're sick, and if you've got a high temperature, they are very effective for if you're sick. But in a lot of cases, people are asymptomatic or low symptomatic and may not show a high temperature. And the skill of the person taking the temperature also is important. These devices are calibrated for either a section of the body, such as the forehead or the side of the head, and at a set distance. It's just like shining a torch on somebody. If you want to get good contrast, you shine it nice and bright, nice and close. If you want shine it too far away, you're not going to see anything because it's just too far away. And so a lot of these temperature guns or temperature probes for non-touch, they have to be used correctly to get a proper reading. So we have this transition zone. And again, the more precautions you take, you dramatically lessen the risk, but there is a diminishing return. The three most important ones is obviously the social distancing, the sanitizing your hands, avoiding touching your face, and now wearing a mask in public. They dramatically reduce the risk. If you do one or two other additional things, then you can have that, again, will dramatically reduce, but you'll keep on getting closer and closer to zero, but the more procedures you put in place may not make that bigger difference. Now, in the green zone or on board the vessel, obviously we want to encourage as much fresh air and sun as possible, not only for the general health, but for mental health as well. Normal duties on the outside of the vessel, cleaning, that can take place. We want to continue, though, the social distancing, especially in crew areas, mess areas, heads. We try to, and there's an idea of what they call interaction bubbles. I'll talk about those shortly. And a very good idea is just to have a really good understanding of your own health as well as the crew. A number of boats I know do twice daily temperature checks and once a week questionnaires. Again, I think that's a very good idea. It's keeping it very fresh in people's minds and keeping it so that if anything does go wrong, you're able, or does get sick, you're able to react to it pretty quickly. Now, what I mean by bubble zones, there was, again, depending on the size of the vessel and complexity, this can be easy or hard to do. But there was a number of anecdotal cases now where families living in very close confines together, where one person tests positive, doesn't automatically mean that they're going to infect everybody else if some basic precautions are taken. And so, and we can use some of those same concepts on board the boat as well. So if we're doing everything we can to try and keep the vessel as clean and as safe as possible, and if once you're on the boat, you just consider it as just one big safe zone, as soon as there's an inadvertent risk or an inadvertent transmission or a contact, then potentially you've just compromised the integrity of the entire safety of the vessel. So one of the ways you can mitigate that is creating these bubbles. So say I've got guests on board the boat, they have a guest area, they've got a play area, and they can do the normal activities and everything that they would normally do, but they are limited to the guest area. So they can't move into crew areas very easily, or vice versa. And the crew that are looking after the guests create a little isolation bubble of themselves, so that they might go to their own mess times, so they don't have it with everybody else. They might have their own dedicated heads. If you've got sharing a cabins, and instead of having a general sort of interior, you might have people pairing up who are looking after guests, so that they are basically isolating themselves or socially isolating themselves to a degree on board the vessel itself, so that if there is an inadvertent exposure to one of the members of a social bubble, it doesn't automatically mean that everybody else is also affected as well. And it depends again on the size of the vessel and the complexity of the vessel. Engineering guys, they could quite easily have their own isolation bubbles, so that the safe operation and maintenance of the vessel can be maintained at all times. Contractors, especially if you're in the yard, they can be sometimes a struggle, as people have to come on and off the vessel. They can be tested in some cases, but they are an uncontrolled environment coming on board the vessel. And so you might limit where they can go, you might limit their heads, you might have some specific precautions about wearing masks, etc., and limit where they can go on the boat. So you're creating this contractor bubble. And then the other group that is something to be considered is that to isolate, if you can, the crew that are going off-site, purchasing, interacting with the general community, especially during periods where you've got a guest or owners on board, and they might create their own little self-isolation bubble as well, so that they take all the precautions going out to buy groceries, food stocks, etc., go out, check restaurants, other areas, or social areas or play areas before the guests come around. But at the same time, when they come back on board the boat, they may create their own smaller bubble as well. So they might have a separate mess time, a separate heads. They might share cabins or an area of the vessel. So again, if there's an inadvertent exposure, they don't necessarily contaminate the entire vessel and potentially shut the whole operation down. So there are some of the things that we can do to try and keep ourselves safe. The numbers will continue to rise. There is very little change from that perspective. And it'll probably continue to rise quite quickly. You'll probably see that there are some common themes on countries that have managed the infection well versus ones that have not managed the infection well. The death rate, true case fatality rate will take a long time to work out, but it's looking pretty high for those susceptible groups. As more people get infected, we're going to start seeing some of these more unusual presentations of strokes, heart attacks, even sometimes gangrene. But these are very, very, very rare effects of the infection, and possibly not even due to the infection, but by your body's response to it. So based on that, generally speaking, you don't want to get infected. I mean, there's a number of, and especially in the early cases where it was just being considered to be similar to the flu, that it was not so bad to catch if you were outside the risk factors. That is increasingly a good indicator that you really don't want to get deliberately infected if you possibly can. And so again, 12 to 18 months, the panacea is going to be the vaccines. There should be an effective vaccine and a safe one coming at some stage in the near future. Until then, we've got to keep following the safety guidelines, the social distancing, the care and caution that we adopt, because it's not so much, not necessarily just looking after ourselves, but our actions and what we do can directly affect the health, safety, and well-being of others, even if we don't know them. So, any questions at all?
I think people will be scared to ask any questions. Good. It's listen, for people that didn't join in the first session, it's more positive than the first one.
Yes, definitely more positive.
Definitely more positive. But it's still a pandemic, so that's just like reality. Obviously bites us in the butts in that perspective. It's how it is. Everybody, feel free to ask questions. I do think it was very thorough, Simon. There's a great presentation. I think that's absolutely the case. I think you let's just look at the major takeaways. If you would have to summarize them in 1, 2, or 3 points, especially for the yachties that are listening now or looking at us. What are the 3 key takeaways that you would give them?
Yep. Be vigilant. The social distancing, the hand washing, and the mask wearing are probably the 3 most important things you can do. Be paranoid, but don't be too paranoid. Would probably be another one. Mm-hmm. And take time to look after yourself, look after others. That mindfulness, be in the present. Don't get tied up watching all the news and the doom and gloom. And at the same time, don't jump on the latest and trendiest either treatment, prevention, or sterilizing or that. Do your due diligence, research it, but try at the same time. Don't, as I said, with doom and gloom. We're coming out of lockdown. We know a lot more about it than we knew before. And what we knew before still works, and we just got to be diligent.
Good. Greg is asking a question: if the antigen test machines can be purchased by the public? Obviously, he's looking to get maybe some for the vessel. Yeah,
they're about £40,000, so it is possible, and there's certainly been a couple of vessels that have shown interest in them. They are, I think, they're very, very good for what they do. There is also non-antigen testing that doesn't require the machine, but they do require a medical professional to operate.
Okay. Even if if you buy the test machines, you still need a medical professional to operate them.
Yeah, and again, it's for some people might be a debatable question, But from my perspective, and the way I look at it, is you can have the best machine in the world and the best test in the world, but unless you do the test correctly, it doesn't matter. And in some cases, you can have up to a 30% miss rate if you don't know how to do the swabs properly. And that's the key thing. It's the person actually operating the machine and the swabbing, not necessarily the machine itself.
Okay, thank you for that. A question on someone who calls himself COVID-19 Situation Update. That's the title of this webinar. Are there any additional precautions we can take on small vessels? What's the best way to sanitize the yard having frequent different guests? It's a good question. We're looking at smaller vessels.
Yeah, that's a really good question. So if you can, keep as much airflow and open areas as possible. So what I've looked at is when you and I are sitting in a room for a long period of time, especially facing each other, we're talking, we're creating this cloud. And if there's not enough airflow through, then this cloud has a chance to settle and propagate. Now, if I've got good airflow through, plenty of sunlight, and the sunlight's always been used as a sterilization agent, but the mist doesn't have time to settle, and it's blown outside, it's diluted, and then the sun breaks it down relatively quickly. So first one, and for me, would be always to try and get as much airflow through as possible, much open areas. If you think about when it comes to sanitizing, the 60% alcohol, 70% alcohol, sort of isopro alcohol, has been recommended as generally probably one of the better cleaning surfaces or cleaning products. Again, has to be used with caution. But on horizontal surfaces, tabletops, etc., that's where a majority of the droplets will land, and they're also the easiest places to clean. So if you set up a cleaning regime or a cleaning schedule every 3 or 4 hours of all horizontal surfaces, get the airflow moving through, then you've probably done a pretty good job. Making sure also that you've got plenty of sanitizing stations around, and if anybody is outside or interacting, that they should also wear a mask, and if they're touching outside objects that haven't been sanitized, like cardboard boxes, etc., that it may be worth having gloves on as well.
Great, thank you. Rebecca's asking if you would recommend continuing lockdown procedures on board if the local area is losing their restrictions, local authorities, but probably, or is it safe to follow local guidelines if there's no active outbreak in the country, for example? So basically, do you follow local guidance, or do you continue your lockdown procedures?
That is a loaded question, that one.
Yeah, it's a loaded one.
Yeah.
So depending on which country, right? If you're Brazil, it's different.
Yeah, it was interesting because as lockdown was starting to ease in Florida, we had boats that were in full lockdown no matter what, and the vessel right beside them was in full party mode. Yeah. So again, I would say use your common sense. The restrictions are not necessarily because there is absence of virus. There's just very low transmission. And again, if we use the states as the example, the states within the US that opened first saw an increase of about 10% in active cases almost immediately. Mm-hmm. So that certainly is a good indicator that as restrictions ease, you can't be less vigilant. You have to be even possibly more vigilant on the social distancing and the basic precautions. And again, it's the basic precautions. It's not necessarily full lockdown that's going to be effective. It's just taking those basic precautions.
Great. What you see as well, because I'm in Spain, obviously, is like we're doing pretty well, and now we're in phase 3. But you see there's a few outbreaks, and they're normally always from some kind of a social gathering.
Yeah, there was a really good one. The CDC have made a poster about it. A choir was singing, and one individual infected 43 other people in the choir during a session.
Yeah, they say that like anything that has to do with like singing or talking a lot, like choir festivals, all those things, because obviously like there's a lot of like expression going on.
Yeah, and a lot of it is face to face as well. So the airlines, although there's not a lot of evidence, but one of the things that's been shown is that everybody facing the same way and having a physical barrier like the seat back can dramatically reduce the spread as well. So the risk when we're in a social environment is we're all talking at each other, and again, and you're right. The louder we talk, the more droplets are spread. they've done some interesting studies on language and that sort of stuff to see if there's any languages that are more likely to spread droplets, and it doesn't seem to be the case. But one of the words that that is used that seems to generate the most droplets is the term "stay safe."
It's the S in there, right?
Yeah.
I bet. I bet that is. Good. I don't think we have any more questions, which means that, again, great session. Thank you so much, Brent. And I hope that you'll join us for more of those updates. And I hope that over time, those updates will become more and more positive. And I hope one day you'll say, like, the vaccine is there, guys, and we're back to normal.
Yep.
Matthew is giving us a smiley, which means I think he enjoyed it. I enjoyed it. Everybody, thank you for joining again. Again, we have recorded this webinar. We'll put it online later for everybody to watch back, or to maybe you want to show it in the crew mess at a certain point, because I think it got some useful information. And as I always say, there's a lot of information going around at the moment, but like it's very hard to figure out what is reliable, more or less reliable in total. Philip thanks us for the update. Well, it's you that he has to thank, Brent. Andrew does the same. I say bye-bye to everybody. Have a wonderful evening, and look after yourselves. Stay safe. Bye-bye.
Bye-bye.
Look after yourselves. Stay safe. Bye-bye.
Bye-bye.